you join Hooray, the first thing you get is you get an email and a text from us. And hey, welcome to Hooray Health. Click here to schedule your virtual wellness. We mail you a lab kit. Virtually all of the providers are primary care physicians. You're not going to get a nurse practitioner or a PA. You're going to get a physician, and they go through and do your family history, your medical history, everything, your prescriptions, and you can see that same physician every month if you want to.
Hey, what's up, guys? Spencer Smith here, host of the Self-Funded with Spencer podcast, sponsored by Hooray Health, ClaimDoc, and PlanSite. Enjoy today's episode. I'm here with Shane Foss, the CEO and founder of Hooray Health. How you doing, man?
Oh, I'm doing awesome.
I gotta ask, when you make a sale, do we yell hooray? Like, is that
we yell hooray and we ring the bell.
Do you ring the bell? Okay.
We have a bell in our office. We are a sales organization. So
I love it, man.
Yeah, absolutely.
That's I want to get to ask a question here in a moment, how Hooray Health got its name, because I'd love to hear that story. But Shane, the normal protocol here is we spend a few minutes getting to know you before we get into the solution itself. But before we get to know you, can you at least position what Hooray Health is so somebody that's listening in will go, oh, this episode is about that. Could you tell us what you do? Yeah.
So we really focus on the hourly employee, whether it's full-time, part-time, 1099, and they have different needs from a health benefit standpoint. And that's where we focus. We've created our whole business around delivering meaningful and affordable benefits for that population. And we do it through a couple different ways. And one of them is technology from a mobile app. We centralize all their benefit offerings on the mobile app. But then we have our own provider network, which is a $25 copay, no balance bill, national. We're in 48 states. Specialized really on urgent care and retail clinics, and it's a very simple model, but it's incredibly effective, and that's Hooray Health in a nutshell.
Well, is there a category, if you will, or are you guys creating? Is it emerging, or is there a name for kind of the category of the style of plan that you guys offer?
Traditionally they were called mini meds.
Mini meds, okay,
right, which is a bad term, but we are what we've done is we've taken that product, which in all honesty, I think if done well, which is what we've done, is a great product because it's a fixed indemnity, and what we do is we add a accident medical expense to it, and sometimes a minimum essential coverage if it's required, and we vertically integrate all of them together into one ID card and one experience. And so the member doesn't have to pay anything up front like they used to, right, with the mini-med. The old mini-meds, if you remember, they would have, a $50 ambulance benefit to make it look, they'd have a list of 40 benefits to make it look like major medical, but, $50 isn't even a tip, right?
Yeah.
And so what we did was we said, look, we're not going to do that. What we're going to say is, here's your physician visits, here's your urgent care visits, here's your lab, x-ray, and we've been around for 7, almost 8 years now, and always doing the right thing for the member, and
I'm glad you said that, well. And that's something that's really from a philosophical standpoint, a mission standpoint. I don't care if it's a self-funded plan, I don't care if it's fully insured, I don't care if it's an ICHRA plan, as we were just talking about. If it's doing the right thing for the member, it's ultimately helping somebody access care. Right. We talked about some of the statistics, which I'm sure we'll bring up earlier, about functionally uninsured and people that don't have savings over $500. It's astronomical. We're at a tipping point. So before we go fully into your solution, I always like to take a step back, get to know who you are, and ultimately to understand the why behind how Hooray Health came to be. So why don't you give us a little of your background, your bio, if you don't mind.
So I grew up in a small town in northern Minnesota, blue collar family, great upbringing. I joined the military. I was in the Air Force. That's what brought me to Texas.
Okay.
And so I've been in Texas ever since. And so I was what they called a scrub tech. And so I worked in surgery. I assisted surgeons during surgery. And I was at Wilford Hall. It was the Air Force's largest hospital. And I just fell in love healthcare.
Okay.
And so ended up, I was going to school while I was in the military. I worked weekend nights. And met my wife. So we've been married 28 years. So
no kidding.
She's an anesthesiologist. And so I started working, when I left the military, I started working for Johnson & Johnson in orthopedic medical device sales. Then I went to
what type of devices were you selling?
Total hip, total knee.
Okay.
Yep. And so and I did a lot of that. I scrubbed a lot of that type of surgery when I was in the military. So, and orthopedic surgeons are kind of my kind of people, and so, it was a great fit. Really enjoyed it. I did that for the first 25 years of my career. So, I was at Johnson & Johnson, then I was at Stryker Orthopedics for most of it. And it was just a great foundation from a business standpoint, a leadership standpoint, and I learned so much, and some of my best friends are still there. And so, speaking of one of my best friends, so when I left Stryker, one of my best friends, Clint Hampton, left, and he was the CEO. He got his first CEO job at a company called Employer Direct.
Oh yeah.
And so Employer Direct was Surgery Plus, so they were insolvent. He said, "This is going to be the shortest CEO tenure if I don't start raising some money. I need you to come in and help me." And so I went in as COO, and I loved it because I'd never been in health benefits before.
Okay.
And what an opportunity. And so we evaluated the business, and I know surgery, and I love surgery. So we fixed the business. We turned it around, sold it in 11 months. And so stayed on for 6 months after that and made the transition. And then actually Clint and I were consulting and in health benefits and really network development and trying to figure out what I wanted to do next. And I had a back issue, and I went into this urgent care, and I had United Healthcare at the time, and I had a $75 copay for urgent care. So I went into the urgent care, paid the $75. I got an x-ray of my neck. They gave me 2 injections, muscle relaxer, anti-inflammatory, and I'm on my way. Well, 3 months later, I get an $800 balance bill. So I call them up and I said, "Hey, you're in network. Why is this $800? Well, you got carve-outs. And a lot of people don't realize that the $75 copay is only towards the physician portion. So what's happened over the last 10 years is that providers and insurers have let them have these carve-outs. Well, so there's no transparency. And so I thought, man, this is an opportunity. So I negotiated it down to $80 because it wasn't contractual. Most people wouldn't have done that.
Yeah.
And so I came up with this idea of, most under the age of 50, 64% of the population does not go to a primary care. They do not have a primary care. So I came up with the idea that we could probably create a bundled or a flat rate in an urgent care. And so I got a bunch of urgent care owners together. I said, "Hey, this is what I'm thinking." We talked through it. And, now 8 years later, we have the same exact contract in the 48 states with every provider.
No kidding.
The same price, $25 copay, no balance bill. Any service rendered under the roof of that facility is covered. And so when you look at who we wanted to serve, which was the hourly population, that is life-changing, because you talk to parents that don't feel comfortable taking their child in when they're sick because they don't know what the cost is going to be. It's heartbreaking. And so we analyzed the market, and we knew that there was going to be an inflection point at some point where major medical was going to exceed really the ability for an hourly employee to pay for it. And so I wrote a business plan. I self-funded it. I bootstrapped it for the first year, and then raised a little money from friends and family, and then went out and got professional money, and here we are.
Well, nice little segue in there, self-funded. I appreciate you throwing that in there. That's the name of the podcast, self-funded. But couple questions going back in time, because there's a lot of good stuff there, and that journey, it seems like a pretty interesting couple of bullet points to get there. I got to ask though, have you always been an operations guy, going in and then turning that business around in such short order? I saw you were the COO, right? Is that do you have an operations mentality?
So I am a total salesperson.
Okay.
And so, but what you do is, you lay out the strategy, and then you hire good people. So Long Tran, who was actually our COO with me at Hooray Health, was actually with me at Employer Direct, and he's the get it done guy, and he's he's the organizational and responsibility side of my brain. So but it's really about getting the strategy and having the right people to execute it.
Yeah, absolutely. And so what about, though, the targeting of urgent care specifically, right? Because there's the primary component, urgent care sits in the middle, and then you have emergent care. Why did the urgent care seem like the area for the most opportunity in your mind? Hooray Health is the manager of the largest employee benefits group captive in the United States. And it's also now the main sponsor of the Self-Funded with Spencer podcast. I chose to partner with Pareto Health for three main reasons. Number one, their dedication to improving the world of health benefits. Number two, their mission to reduce volatility and to make self-funding simple for mid-sized employers. And number three, the strength and scale of their program. With over 2,300 member groups and more than $1 billion of stop-loss premium under management, Pareto Health is the most robust solution of its kind in the country, period. Stay tuned for more information because I'm sure I'll be featuring them on an episode of the podcast very soon. Visit Pareto Health at paretohealth.com or follow them on LinkedIn to stay up to date on the latest news and developments.
So it's the fastest growing segment of the healthcare delivery model, right? It's the most convenient. I mean, I'd been going to urgent cares for years because they're open 7 days a week. They have on-site lab, on-site x-ray. I don't want to take off time in the middle of the day to go see a primary care physician for something that I can walk in when it's convenient for me to go see a physician.
Yeah.
And unfortunately, we've been trained over the last, 50, 60 years that showing up for an 8 o'clock appointment and being seen at 12 is just the way it is in a physician's office. And I don't operate that way, and nobody else should either. So I really like the urgent care, and I know that as a young person, I've got 2 kids that's where they would rather go, right? Is something that I can go in and, you look at, millennials, you look at Gen Zers, Gen Xers, they're about the experience. They're very pragmatic about their care, right? You talk to my mom, boy, she loves her physician. She would never see anybody else, right? But I talk to my son, he's like, I don't care.
Yeah.
Right?
Yeah, whoever can get me in. And
exactly. And so...
Well, you've almost replicated, and we'll structurally talk about the setup here in a moment, but it feels like you've replicated somewhat of the direct primary care, the capitated model for primary care with urgent care. Is that a good way to put it?
I think it's a great way to put it because we actually looked at direct primary care first, but the challenge was at the time, it wasn't scalable. And so when you look at who our target audience, who I was looking ahead, was going to be the large jumbo clients like a Lululemon, a Topgolf, where they have a footprint nationally. I wasn't going to be able to deliver on the direct primary care like I was on the urgent care. And so the urgent care really was just a great fit.
Okay. Well, and so with that, though, we'll get into the plan in a second. I do want to make sure we don't go too far, too fast because it sounds like, hey, you had some conversations with some guys, you set up a plan and were successful 8 years later. I know there's obviously a lot more to it than that. When that round table or that mastermind, if you will, of the urgent care doctors, like what really culminated out of the early days of that? What were some of the ideas? What were some of the opportunities that you discovered?
Well, it's interesting. We sat down probably for 5 hours with this group, and it was really, I asked them, what are the most common things that you see? What are your pain points? What are the issues when patients come in and they don't have insurance or they have insurance? What are the issues? And we walked through everything and wrote everything down and went to a carrier and said, hey, can we do this? Can we do that? And we worked through everything. And then I went back to him and said, hey, this is the contract. And they were like, this is perfect.
Perfect. Really?
Yeah.
Well, that's interesting. So there's a common theme that I've discovered sitting down with entrepreneurs. And I can't tell you how many have had that $800 balance bill scenario. I mean, it's almost that number seems to be the sweet spot to trigger action, if you will. But it's always interesting when you go through that experience yourself. And obviously you were doing well at that time, but that $800 bill was still egregious enough for you to go, well, what the heck? And then ultimately start a business to solve that problem. So once you got that contract in place, you mentioned that the DPC model is limited, right, in its ability to expand. How did you overcome that? How are you not limited by the same geographic constraints?
Well, so what we did was, unfortunately, there's not a centralized, phone book of all the urgent cares or all the providers in the country. So I literally just networked myself for the first 2,000 and would network in, sell my vision, because we didn't have any lives at that time, and would get contracts.
Okay.
And so we strategically looked at all of the major metro areas, the top 50 major metro areas. And when you look at and when I say top 50 major metro areas, Dallas Fort Worth would be 2 metro areas, but it really combined it's 1.
Sure.
So when you look at the top 50 metro areas, strategically, 82% of the population in the United States is within 20 miles of that metro area. So that's where we targeted initially, and so we literally just would call, set up appointments, and sell the vision, and they would.
So you had to sell the vision to those urgent care providers first, right?
First, yeah.
So you had that network had to be structurally in place. So how long did it take to stand that up where it was sufficient to go then sell it to membership?
6 months.
6 months.
6 months to start, and then and we started in Texas, and then it grew pretty rapidly. And we add over 35 a month new contracts.
No kidding. Okay.
Yeah, we have over 50% of the urgent cares in the United States contracted today.
No kidding.
And so our footprint. So when we do a geo analysis for, let's just, Target is not a client, but I'll just use Target because I remember we did one for them. And we, with their stores, we had 85% of their population within 10 miles of a contracted provider of Hooray Health.
Wow. Okay.
Yeah.
Well, that's right. And then, so when did it hit that critical mass? That 6 month point when you could start going to sell a group? Now, is that when you start? Okay.
We started in Texas. We had Texas, Oklahoma. I'm trying to think where else. Arizona was the other one where we had good coverage, and so we just started selling in those areas. But then within 2 years, we could go national, but it was really probably 4 years ago. So it was probably at the 3-year mark where we really started getting scale and getting national clients. It's amazing because we started with really Aflac reps selling our product, and a lot of small independents, and then we really learned how difficult it was to manage the small group through that process.
Okay.
And so then we started going upstream, and we brought on new investors, and then one of the gentlemen that joined us was Russell Huber, who's a great guy, unbelievable sales guy, and the best I know, and we started selling into the large brokerages, the Lockdons, the Gallaghers, the Mercers, and they're who have the large clients,
of course, yeah,
and the Holmes Murphys, right? And so and then we started grabbing selling national clients, and knock on wood, we haven't lost a client in 4 years.
No kidding.
No kidding.
Oh.
Siemens Energy has been with us for 5 years, and
that's an incredible retention rate.
Yeah. We've done really well, and so it's interesting. You talk about overnight successes, and people are like, oh yeah, you had a great idea and it just happened. COVID killed us. Nobody wanted.
Okay.
Yeah.
Okay.
Nobody wanted to move. Right. They didn't want to do anything different. So COVID, we just stayed stagnant. But we kept all of our business, but we stayed stagnant, and we learned. But what we really learned was we built the core competency around implementation, client management, and our implementation and client management team is world class. It's funny when I go to brokerages, and the ones that I call on, and we're talking, and they're just like, your implementation team and account management is unbelievable, and we just take all the worry out of it for them, and the hassle, because it's interesting is hourly benefits are completely different. And when you're a broker for 20 years, even 10, 15 years, your focus is always on major medical, which I understand. I wish everybody could afford major medical, but it's just not the case. So they really lean on us, and that's where we focus. So it's really good.
Well, what do you think? If you could put your finger on maybe the why have you been able to be so successful in implementation? I mean, was it just a very intentional focus on it, or just great people, all the above? Like, tell me what's going on there.
Yeah, great question. So it was intentional in the sense that we put a ton of focus. We had when we were getting these larger clients, our participation was not where we thought it should be. So we put some focus on it. We brought in a lady, Deb Lamoureux. She'd worked at Aetna and client team, and she's done an incredible job. And then Troy Rockman, who runs our implementation side, with their leadership and guidance, what's happened is they've really taken ownership and just to improve the process, listen to what's going on, and they really treat it like Troy's almost like a process manager, if you would, right? Where he is just, okay, we send out the information after every meeting, and here's next, and it's just the workflow, and we've just put so much structure, and so it's but ideas are always great, but people have to execute.
You got to execute, yeah.
So, I am incredibly blessed. My team is unbelievable. I mean, I've been in senior leadership for a long time, and this is by far the best leadership team I've ever had.
Well, it's amazing. Well, then it's obviously there's no accident in terms of the success of the organization itself, like from an implementation side. So I'd like to, if we could, segue into the product itself, right? Let's really talk about the nitty gritty of what it does, who it serves, and how it's structurally built. So why don't we start with the what? What exactly is this product? We talked about it briefly before. Let's go deep into what it does.
Yeah, absolutely. So it is technically from an insurance product, it's fully underwritten. Okay. So it's fully insured either by Zurich or National Guardian Life. And it is a hospital indemnity paired with an accident medical expense, no deductible, 100% of usual and customary on the AME, and then depending a self-funded MEC, minimum essential coverage. And so it's all fully integrated through our TPA. We use one ID card.
Okay.
And so it is a plan really for sickness and illness and accident, plus you can add preventive. With the minimum essential coverage. We focus on the hourly population, whether that's full-time or part-time. I'm sure a lot of your listeners are going to start putting two and two together, because participation on the hourly side has gone down dramatically with major medical.
What's it at on average? Do you have a statistic for that?
I don't know what it is on average right now, but it's just to give you an idea, we've had clients where we talked earlier, we never really lose to a competitor. We lose to just, hey, we're putting this off this year, right?
Okay.
And we had a client, we had two last year that were significant clients, 10,000 plus, and they went down to 10-13% participation. Jeez. And they said we have to figure something else out. Yeah. And the challenge is, in that market is, as an employer, if you're at a $5,000 deductible and you're paying, a lot of times to make it affordable, 50 to 70% of it, you're doing the right thing, and then you still don't get the participation. And if you have a self-funded plan, that hurts, right? Mm-hmm. But then from a carrier standpoint, you may have requirements. Look, you need 50% participation, right? So that hurts them as well. And so, we do a lot of management carve-outs where we'll do something special with the hourly, but that's who we focus on. That's really the problem that we're solving. But going back to the product, what we've done is we've created some really unique products. So when you look at our vision statement, it's really we help people through affordable and meaningful benefits that increase access to healthcare. Okay. That's our focus. And so when I say meaningful benefits, I'll give you an example. Our primary care payment, our daily rate is $100. Okay. Well, we use First Health as our wrap network. Average contracted rates usually about $68 is what we see. So they're getting a check for $32 on top of that, and then our lab benefits are $50 per lab. Well, our average CBC is $12, right? Okay. So we give meaningful benefits. Our goal is that they have zero out of pocket at the time of service, right? But when we looked at our benefits, we went to the CDC, and then I think it's IHS. We looked at the data. We said, okay, what's going on in a given year for our population, which is really under the age of 50. And 2 physician visits a year. You've got labs and x-rays. Accident is 12% of the cost, right?
Okay.
And then less than 5% is hospitalization. Well, then you look at the hospitalization under the age of 50, 92% of it was pregnancy related.
Really?
Right?
92%?
92%.
Okay.
And so when you look at that, you're like, okay, we need to do something, meaningful if we're going to sit underneath a high deductible for a pregnancy. So, our lowest plan will pay up to almost $5,800 to subsidize to help. You should have major medical if you're pregnant, but for a 2-day stay, right, with baby and mother and baby. And so again, meaningful benefits, so we can help take care of that $5,000 deductible. But when you look at what happened traditionally in mini meds, just fixed indemnity, it was always just meant as a supplemental where you submit a claim, you get a payment back. Well, we changed that paradigm because we push eligibility to providers with our ID card, so they identify them as insured and they bill us, and then we adjudicate the claim.
Okay.
Well, and then from a plan design standpoint, we really focus on, okay, historically, even though we know that the average person is going to go see a physician 2 times a year, right? If I see a limit of 2 times, that's a limit in my mind, right? Even though we know that they're not going to exceed that, but that's fine. So what we've done is we've created what we call our max plan. So we have a bucket of money. So we start at $5,000 and go all the way to $90,000, and those daily benefit limits are basically pulled out of that $90,000. So let's say if I go to the hospital for the first day, it's $3,000, $1,500 a day after that. Surgery is $2,000 or $2,500. Outpatient surgery, $2,500, $500 anesthesia. That comes out of that $90,000 bucket.
Okay.
But if on the $5,000 plan, which by the way is only $55, right? I can go to an urgent care 32 times. I could see a primary care physician 50 times in a year, right?
Okay.
There's no limit except for the bucket of money.
The absolute dollar amount. Yeah, okay.
Yeah.
Well, so as in terms of application of an individual, right, we mentioned the hourly employee. Obviously, I presume that means a little bit lower waged employee as well. So what is ultimately compelling me? Why would this be a fit for me instead of, buying my employer sponsored plan, or obviously the other side is go without? What specifically are you solving for me in that persona type?
Sure.
PlanSight is a complete game changer in the world of insurance brokering. As a broker, you know how time-consuming and error-prone the traditional RFP process can be. Well, what if I told you there's a better way? PlanSight is the only end-to-end RFP solution on the market made specifically for benefits agencies. It's like having a superpower that gets you an average of 8 to 10 hours back per employer renewal per year. And the best part? PlanSight supports all carriers, all funding types, and all group sizes for over 20 different benefits. If you're ready to make your RFP process faster, more efficient, and more profitable, it's time to call PlanSight. Visit plansight.com now to book a free demo and discover the future of insurance renewals.
So I think we solve a couple things. So 50% of Americans don't have $500 in their bank account. So if they have a $5,000 or even $1,000 deductible, they're functionally uninsured. They can't use that plan. The other issue is that when you look at the family cost, it's just got to be devastating to know that if I can't cover my family, even though my employer is covering me, I can't cover my family, and so that's. And I'm
also paying a lot of money in premiums every single year too. Yeah.
So what the problem we solve is we're first dollar coverage, so it's meaningful benefits for, if I have. If it's myself, my wife, and my kids. I mean, I literally look at the last 20 years of my kids and us. We've had Hooray the last, 8 years, 7 years. And the only thing, and we've had major medical as backup. I'm 53 years old. I'm using my major medical for the first time.
Really?
This year.
Really?
Yes, for the first time this year. And so everything else has been Hooray. And, I showed you I had 14 stitches in my hand, and I went into the emergency room. My son drove me to the emergency room. I gave him my insurance card. They were like, okay, head on back. They stitched me up, washed me up.
Was this a dad at home injury? I'm trimming the plants or something? What am I doing?
Well, actually, my son and I, I had bought him a very large RC plane for his birthday, and we were getting it ready to fly. And we were just in the house, and I tested the motor, and it connected, no problem. I was just literally going to disconnect the battery, and I handed the remote to my son, and he didn't touch anything, but all of a sudden the motor just came on.
So the propeller,
and this is a very powerful motor. I mean, the propeller has got to be maybe 6 inches in diameter. And so I just instinctively reached with my left hand and to stop the motor so it didn't hit anybody or anything. And yeah, it was pretty bad. It was pretty bad.
The scar looks okay now. I was just curious because my wife did not something similar to that, but I come home one day, she's like, hey, I cut my hand open pretty bad. I'm like, oh, maybe she cut it, chopping food or something. I come home and she was trimming the hedges with one of those electric hedge trimmers because my wife's a little bit like, she's a go-getter. So if I'm not going to be home in time, she's like, I'm going to do it. And next thing I know, I come home, there's a blood trail leading out the back door. I'm like, what happened? And she just cut it deeply. Luckily, didn't lose a finger, but I mean, she cut pretty deeply into her hand, and it was just like, geez.
I know. But what did you pay for that now? That's the next
so
question.
I can tell you, we paid about $1,300 for that.
Exactly. Yeah, mine was
really
$980.
Yeah.
But here's the other thing that's amazing is my son, literally 2 months later, he's a photographer, works at a bank, but he's a photographer, and he was driving to a photo shoot and ended up getting in a car accident. And my wife's cousin lives downtown Dallas, so he actually was kind enough to go over and pick him up. And he took him to the emergency room down at Baylor, and they gave him our ID card. They accepted it, and they did a CT to make sure he was okay. Gave him, cleaned him up a little bit. He had some glass in his face. They had, and then they gave him some, drugs to kind of calm him down. He was pretty upset, and I thought, oh, what's this bill going to be?
Yeah.
Well, we get the EOB, and it was $4,900. They were in First Health Network, so it was down to $1,700. We pay 100% of it. Then we got the emergency room doctor bill, which they're out of network, and it was $498. We paid 100%.
Really?
So, literally in 3 months, I paid for my whole premium cost with Hooray Health.
That's amazing.
For probably 3 years just with those two bills.
That's amazing. Well, I want to divert a little bit, to maybe just expound upon, not divert though. We haven't really covered prescription side of this.
Sure.
Yeah. So that's, I know, so especially in my world, we're thinking about all the scary giant gene therapy drugs and things like that are really big stop loss claims. But somebody that's doing this might have maintenance drugs. They might have things that they need to take on a routine basis. So how does Hooray address the PBM side of the equation?
Yeah, absolutely. So what we do is we have RX Valet is our PBM, and so we have $0 cost acute. So if I need an antibiotic, something like that, $0. We have $5 maintenance drugs, chronic drugs, copay, and then if there is a crazy drug that they need help with, we have a prescription assistance program within RX Valet. We have international sourcing, and we get discounted diabetic supplies. But for the most part, when you look at the top 50 prescriptions, we're taking care of those for either no cost or $5, right?
Okay.
And then of course, anything that's not on that, we have a discount program that's all built into our mobile app.
Okay. Well, I want to ask you though. There's got to be some inherent limitations, right? And I think you've addressed a little bit, and I do want to really hit those head on. But my brain is thinking about the truly catastrophic stuff, right?
Sure.
The heart attacks, end up in the hospital, maybe a NICU baby, things like that. So where does it stop, right, in its utility, or what are the gaps, if you will, if somebody's evaluating this for themselves?
Absolutely. So one of the things that we have up front and center in all of our employee trainings, our client trainings, everything. We are not major medical, and we're not major medical on purpose, right? Mm-hmm. We know the group that we serve. We don't compete against major medical. We compete against not having insurance.
I see. Okay.
That's exactly what we do. And so when you look at where we fit, we take care of, we really fit in a couple different places. So when you look at an employee that may go get a subsidy on the exchange that because they weren't offered an employer sponsored health plan, we can sit underneath that $7,500 deductible that they're going to get, even though it's free, right? We can take care of all their basic needs, and that's what we really focus on, is the basic needs. When you look at any catastrophic event, it's going to be just like if you were not insured. There is not a catastrophic event. So if you had an accident, our accident coverage is either a $5,000 per accident or $10,000, depending on the policy or the plan that you choose. It would limit out at that $10,000 or $5,000, and so, we understand that there are going to be catastrophic events, and we've seen them, and they, and it's a risk, and we want everybody to have major medical, but the reality is,
well, it's obviously you're serving a need. Yeah, there's uninsured or functionally uninsured,
right.
Whatever term you want to use. There are just some people that flat out couldn't afford it even if they needed it, right? And so at least there's something there. I think that's similar to what like the medical cost sharing services are trying to, that opportunity zone they're trying to address as well. You guys are just going about it in a different way. But how do you feel like you evolve? How do you feel like you stay up with the demands of the marketplace? Like what are some of the things you guys are continuing to think about adding or bolting on and stuff like that?
Absolutely. So this year we actually added on the RX, the more robust RX. So we're really excited about that because we saw that as something that we needed to do. The other thing is we converted over from just a traditional telemedicine to a virtual primary care this year, and that is a game changer. And the reason is because our goal is always to limit the out-of-pocket costs for healthcare, period. I mean, if we can do it for zero, we want to do it for zero. And we've lived by that. As a matter of fact, just to put it in perspective, when we started, our product had fewer benefits and it was 30% higher. We have not had a price increase in the last 7 years.
No kidding.
We've only reduced our cost and we've improved benefits. So when we find partners, we are always out evaluating how do we improve what their access to care, but keeping the price at a reasonable rate, and that's our goal. So when you look at what are we going to need to do next, I think as we continue to see more and more hourly mid-level people that can't afford major medical, we're going to need to take that 90,000 up to $500,000 or $1 million and add some more hospitalization and stuff like that to make it more meaningful. I think that when you look at the other trend in the market, which is this 1099 gig space, we need to have an individual product, which we're getting ready. We're going to launch that 1/1, and that. But it's not going to be just for the gig worker. It's going to be for anybody that needs a supplement underneath their major medical, right? That has a high deductible plan. So I think that's going to be an area that we're going to serve, and we're going to serve it very well. But when you look at where we are today, we're really addressing basic needs, and eventually it'll be we'll find the right avenue to take a more catastrophic look at things. Yeah. But it's never going to be major medical. That's not where we want to play. We don't want to be in major medical. We have a really nice niche, a nice focus where we can stay with the people that really need the help.
Yeah. Well, before we zoom out to the big picture stuff, I do want to address it. I know quite a bit of the audience that listens to this are your consultant. So your brokers, consultants work at agencies. And so they're probably thinking about right now, like, well, this might work for this firm, or I got a group in mind. Talk to me about kind of the brass tacks of engaging with you, kind of the timeline for adding a plan like this to a population. What does it look like just to execute on this in the group setting?
Yeah, absolutely. So if they can reach out to us at hoorayhealth.com. They can reach out to me on LinkedIn, Russell Huber or Chris White, other sales leads for us. But it usually takes between start to finish, presenting to the client, getting the client to sign off and everything. It takes typical 60 days like anything to implement for open enrollment.
Okay.
We just need everything signed 45 days ahead of time, and then we're good to go.
And reemphasize the type of employer population, right? We mentioned hourly or part-time employees. Are there certain industries that tend to be a good fit? Sure. Talk to me about that stuff.
Yeah, so it's interesting because when we first started, we do a lot in the restaurant hospitality space, which makes sense. Do a lot in the retail space, but there are a ton of industries out there that you wouldn't think of that have a very large hourly population. And so, when you look at, as a matter of fact, we're implementing a large workers' comp physician office right now. You've got physicians making, whatever they're making, but then the rest of the staff is all hourly, right? Yeah. And so those are perfect fits, right? So any place where there's a large hourly population, nursing homes, long-term care, you've got a lot of manufacturing, you've got, the people that, you got the people that are doing the work at the airports, that's all out. They don't work for the airport. They're outsourced, right?
Okay.
That are doing the baggage handling and stuff like that. Security firms. So there's a lot of hourly opportunity out there for sure.
That's amazing. I presume obviously there's a little bit of an education process, but once a member has been presented this solution, relatively easy, straightforward for them to understand what it is and what it's not.
ClaimDoc is a medical claim auditing and member advocacy company. We provide fiduciary services to employer-sponsored benefit plans and allowing them to create an environment where we ensure that the benefit plans are being charged in a fair and reasonable basis.
My business is basically people, and it become a real simple transition. We thought it was going to be far more complex. I've saved, we'll say, hundreds of thousands of dollars. I could not say enough about ClaimDoc.
Yes.
Okay.
Yeah. We even have videos. We are not major medical, and we want them to know that we're not major medical and what we cover, that we focus on the basic health needs. But, we communicate on a monthly basis via text and email to our members. It's whether it's flu season, whether it's, hey.
You guys got the great app too. You showed me a little bit of your app.
We're just getting ready to start geofencing. So when you drive by one of our contracted providers, it just pops up, hey, if you're sick, don't forget you can go over here. Yeah. So we're doing a lot of that because we're doing a lot of education on emergency room versus urgent care right now. We want to make sure, we look at our utilization and if we see somebody went to the emergency room for a UTI, that is to me a failure, right? Okay. And so I want to make sure that, and I should say we want to make sure that that they're getting the most out of their benefits and they're using their benefits. And so one of the things, just to give you an example, when you join Hooray, the first thing you get is you get an email and a text from us and, hey, welcome to Hooray Health. Click here to schedule your virtual wellness. And it's a no-cost virtual wellness. We mail you a lab kit.
Cool.
You prick your finger, do the blood spot, you send it in, and then we have virtually all of the providers are primary care physicians. You're not going to get a nurse practitioner or a PA. You're going to get a physician, and they go through and do your family history, your medical history, everything, your prescriptions, and you can see that same physician every month if you want to, but they can manage your chronic disease state as well, whether it's diabetes, hypertension, high cholesterol. And so what's nice about that is they will send it to our contracted lab provider, which is Quest Diagnostic. they'll get the lab. They can go to any lab draw, get the lab, and then they can go through their labs with them. And so they don't have to leave their office. They can do it from home. They can do it wherever. And so even if they want to have their primary care physician, it's great, but they can work in tandem with them. And so, we're trying to improve the health of this population, which is, they just forego health because healthcare coverage because they can't afford it.
Well, nobody wants that. Nobody wants that for the individuals. Nobody wants that
Exactly.
for the system itself, right? Because what happens when you delay or don't get care whatsoever? It becomes catastrophic, either deadly or unfortunately really, really expensive or both. So we're trying to defer that from happening. What about big picture stuff? Let's zoom out here real quick and just talk the big picture of our system itself.
Sure.
And then I'll ask you for your closing thoughts. So Shane, where are we going with healthcare, right? What is your vision of what healthcare might be in 5 to 10 years? And maybe what role does our government, if anything, have to do with it, or could we stave off the public type arrangement?
I think my favorite saying, and anybody that knows me hears this from me all the time: pigs get fat, hogs get slaughtered.
I literally said that this morning.
Yeah, and they're going to put that on my gravestone because we are, when you look at nationally, the impact that healthcare costs are on the greater GDP, it's too high. Mm-hmm. And we're coming to a point where something has to be done. And unfortunately, I'm sure it's going to be some type of government intervention, right? How I would imagine it would be, your Uniteds, your Blue Crosses, the BUCAs, they're going to do something just like they do with Medicare Advantage, right? But what most people don't realize is that there's cost to that, right? I mean, from a tax standpoint, there's out-of-pocket costs, right?
Of course,
you look in Japan, they just raised it up to, I think the first 9,000 is you. So, with Hooray, I think we have a future there. We're gonna, we'll sit as a supplement to that, and because we have that transparency and that fixed payment, and that, I think it's going to be interesting. I think that's where we're going. I think transparency is going to become more of an issue. I think you're going to go to smaller health systems. They're going to have to break up these major health systems. Mm-hmm. We just like they did the baby bells, right? They're going to have to break them up. I think that transparency has to come to the forefront. We talked earlier, right? What's funny is we already have fixed pricing. It's Medicare, right? Medicare rates. Medicare, they already have bundled surgeries through DRG, right? Mm-hmm. We have to go to that level where because it's like me going to Walmart and I pay $5 for a gallon of milk, and I walk out and 3 months later I get a $100 balance bill.
Yeah.
How does that happen? There's no common sense, and what I'm hoping is that there's going to end up being some common sense here, right? Because even from there's no correlation between cost and quality in healthcare. Yeah. And we need to get to that point, and somebody has to in the government has to, work with industry to say, hey, we've got to rein it back in, and there's no reason the government should be paying $12,000 for a total knee, and Blue Cross Blue Shield should be paying $45,000, $50,000, right? And I shouldn't say Blue Cross because it's really us paying that, right? Yeah. And there's no reason because it
literally leaves you like almost dumbfounded.
Well,
like
exactly.
I'm just literally saying, trying to describe it and make sense of it. You just come in this circular, like, I can't, how do we get here? And that's really what it feels like some days is how do we get here? And that's why I make it a mission at least to talk about how do we get out of here? How do we get away from this? So why don't you give us your closing thoughts, Shane, before we part ways, man?
Well, I think, there's a lot of innovative companies out there right now. And it's capitalism is great. And that's how you continue to innovate. And there's we're going to innovate our way out of it, hopefully. And I think that the good news is we've got really smart people in the industry. We've got really, people that want to do the right thing. So hopefully we can get through this together. But I think that, we're just going to continue to, for us, we're going to continue to innovate. And, we talked about dependent coverage. We've got dependent only now, right? So, we can sell our products so you can accept major medical. There's other groups out there that are doing great things that are solving niche needs, and we need, as brokerages and other companies, we try to support our innovative partners, right? We're always looking for them, and we want to help them. And so as a broker, getting to the innovative companies and working with them and helping them, innovate and put them in front of clients is a great thing.
Well, that's what I fortunately get to take a relatively neutral stance or agnostic stance on this podcast, and I do that intentionally. It's because it's not really my job to judge what's best for a particular employer or for a consulting firm. But by presenting these ideas and presenting an array of ideas that solve different problems, my hope is that the marketplace will figure out which ones actually work and which ones not so much. And I really wish you nothing but success. There was obviously a good reason why you were referred to be on the podcast, and I'm going to have to give Kyle my thanks for him doing that. But it was great to meet you, Shane. I hope this is just the first of many meetings, and I wish you luck with Hooray Health.
Thanks, Spencer. Same with you.
Thank you.
Really appreciate the opportunity.
Absolutely.